Okay, so our finalist for this morning before lunch is Professor Anasir Rahman. He runs a big antiphospholipid syndrome group at University College London. He's done a lot of work on the sort of the mechanisms of APS, and is also beginning to think about new treatments for APS. So Anasir, thank you very much for giving us your time today. And let me see if I can get your slides up. That's you. And then F5. Thank you.
Thank you very much, Ian, and thank you to the organisers for inviting me to give this talk in the patient session. And this is my disclosure statement. So when I was asked to give this talk, I was thinking, how will this be different to the talks I normally give at these meetings? And what occurred to me is, what would patients want from a talk like this? And the difficulty for me and people like me in giving talks to patients is that we aren't patients. So I might be able to tell you a lot about the science, but I don't know what it's like to have a diagnosis of antiphospholipid syndrome. Nobody's ever told me I have to take warfarin or have to have my INR checked, or that I might be at risk of a stroke. So I don't know what that feels like. On the other hand, in recent years, I have had the experience of being on the side of the doctor-patient consultation because my mum got ill, not with APS, but with another reasonably serious disease. And I found myself on the other side in that consultation where the doctor was saying to me and my mum, who is non-medical, "These are the treatments, this is what we think you should do, this is what's going to happen to you." So that was a lesson, something which taught me a lot. I didn't enjoy it, but I learned a lot from it. And so I'm building on that experience to give this talk, because what I and my mum wanted to know from those consultations were things like this. What is this disease? What will happen to me? What can I do for myself? What treatment am I going to have, and how long for? Why is that the right treatment? How do you know? And side effects? And are there alternatives? So that was what we wanted to know, and that's what I'm going to try and cover in this talk. And in order to do that, I'm going to have to touch on history, philosophy, and science. So the history is, why do we treat APS the way we do? How has that come about over the years? The philosophy is, what is the aim of treatment? What are we actually trying to achieve in treating people? And why is it so hard to change things? Why don't treatments for this disease change quicker over these? And then the science is, how are things likely to change in the future? So let's go to the history first. What is the antiphospholipid syndrome? Now, it's very rare that you'll actually meet a person who could claim to have discovered a new disease. But if you meet Graham Hughes and Nigel Harris and the people who worked on that team, they could genuinely say they had done that. So in the early 1980s, a lot of people were working in the field, but it was Hughes and Harris and their colleagues who'd made the great breakthrough in a paper published in The Lancet. This is a new disease that people didn't know about before. And the two very clever things that that group had done was they invented a new test, a new blood test, which would detect these things called antiphospholipid antibodies in the blood. Nobody had that test before. The other great leap they made was to link this to a particular group of patients. They said people who have this test are more likely to have clots or strokes or miscarriages. So those are the two things, and that's what makes the syndrome. So that was in the very beginning. That was the definition. And over the years, the definition has changed, but not very much. So the current definition, which dates from 2006, is this. Miakis was the person who published, and if you want to look at the actual paper, that's the reference for it in the Journal of Thrombosis and Hemostasis. But you can see our currently operative definition is not that different from the definition all those years ago. A patient with this syndrome has to have clots and or pregnancy loss. They have to have positive blood tests. The only difference between now and then is that there are more blood tests included. Back in the beginning, there was only one blood test. Now there are 3 blood tests, anticoagulation, lupus anticoagulant, and anti-beta-2 glycoprotein 1. And you can be positive for any one of those, but you have to be persistently positive. So then and now, the disease means you have these clinical features and this blood test. That's what antiphospholipid syndrome is. So then back in the 1980s, this led to a very kind of simplistic way of thinking about antiphospholipid syndrome. This is what we were all talking in medical schools in the kind of 80s and 90s, and it looked a bit like this. So we know that it's caused by the antiphospholipid antibodies, and the T is that phospholipids are really important in clotting. You need phospholipids from clotting. So hey, your antiphospholipids, you've got phospholipids, put them together, you're going to disrupt clotting. And we know that the people with these diseases get disrupted. They get clots in their blood vessels and they get clots in their placenta. That's what people thought in those days, which caused miscarriages. That's what people thought was going on. And you can see it makes sense. It's very logically consistent, this idea. It's actually wrong. And over the years, we've found out more about why it's wrong. And I'll come back to that later. But back in the very beginning, this idea said, well, clearly the treatment of this disease must be to suppress clotting. Everything is caused by clotting, so we'll give people drugs to stop clotting. These are the drugs that we call anticoagulants. And this is why from the very beginning, throughout the history of the antiphospholipid syndrome, the treatment has always been anticoagulation because of that. And what do we mean by anticoagulation? Well, we mean drugs like warfarin and the direct oral anticoagulants, or DOACs. So warfarin is given in tablets, and the thing with warfarin is you have to have very regular blood tests if you're on warfarin, and the reason for that is warfarin is unpredictable. So if you take the same dose of warfarin every day for 2 weeks, it won't necessarily make your blood equally thin on all of those days. On some days, your blood might be really, really hard to clot, so you're likely to bleed, and on other days, your blood might be very, very likely to clot, thinner on different days, even though you didn't change the dose of warfarin, because the effect of warfarin is really unpredictable. And this is why people who take warfarin have to have blood tests done very regularly, sometimes every week, to check they're on the right dose. And that's something which is really inconvenient about warfarin. Heparin, on the other hand, is given by injection. You can't take it as a tablet. And people who are on heparin usually are because they can't get on with warfarin for some reason, or during pregnancy, as you heard from Claire, because warfarin cannot be given during pregnancy. It's bad for the baby. And the DOACs, these new drugs, are like rivaroxaban. I'm going to come back to those in a minute because they're a little bit of a hot topic at the moment. But all of these drugs are not specific. None of these drugs is specifically made for the antiphospholipid syndrome. They don't interact with the antiphospholipid antibodies. They just repress all clotting. And this is a bit like trying to stop burglary by running a police state. So if you imagine a city where there are burglars around, what you really want to do is target those burglars, put them in jail. Okay? But you could stop burglary by putting a tank on every street corner and soldiers everywhere. You'd definitely stop all the burglaries then, but there would be a price. And warfarin is like that. Warfarin is like repressing all clotting. It doesn't distinguish between the bad clotting and the good clotting. It just represses all the clotting, even the clotting which is good for you. So it's not a very specific way of dealing with a disease. Warfarin isn't, heparin isn't, and DOACs aren't. So I want you to remember that thought, because later I'm going to come back to how we could be more specific in treating the syndrome itself, rather than just repressing all the clotting. So now the philosophy. If I'm going to put somebody on warfarin, long term, why am I doing it? What is a success? What does successful treatment look like? What is the aim of the treatment? And in fact, the aim of the treatments are these. Firstly, to stop recurrent clots, to stop people having a second or a third clot. Somebody who's had a clot, I don't want them to have another clot. Success is they don't have another clot. And warfarin is good at that. There's lots of evidence saying that it's not perfect, but it's good. To stop a recurrence miscarriage. So if a lady with APS has had a miscarriage or 2 miscarriages, can we stop that lady having further pregnancy problems? And with heparin and acid, you've heard, we can do that. This is a successful form of treatment. But what about to reduce daily symptoms, things like the brain fog and maybe joint pain and so on? Actually, that is not the aim of giving warfarin, and there is no proof that warfarin would work for those things. Because warfarin and heparin and so on will only work for things which are actually directly caused by clotting, because they stop clotting in general. So the daily symptoms not due to clotting may very well not respond to those drugs. That's why many people with phospholipid syndrome who are on these drugs still have symptoms, because the drugs we're currently using were not designed to cope with those symptoms. But there's a bit of a logical inconsistency in the slide I've put. You see what I've put in capital letters, to stop recurrent clots, to stop recurrent miscarriages. We're giving the drugs after somebody has got ill. Somebody has had an event and then we're giving them the drugs. So why do we have to earn the drug by suffering a thrombosis carriage? Why can't we just give it to them to stop the first one? Why don't we just find out somebody's got a positive test and treat them straight away so they never have a clot in the first place? And that's a philosophical thing. And the reason is there is a price. These drugs have risks. Warfarin, heparin, and DOACs can all cause bleeding, and that bleeding could be severe bleeding. Warfarin is not safe in pregnancy. Heparin can cause thinning of the bones, and they're inconvenient to take. So, daily injections every day. Do you want to do that? Warfarin, do you want to have regular blood tests? Does one want to do that all the time? And also it has lifestyle effects. So, for example, if you're keen on contact sports, you're not going to really be able to do that anymore if you're on warfarin. It affects what you can eat, what you can drink, and so on. So this is not trivial, and this is long term. So what you're doing by giving these people drugs like this is asking them to take on something really big. You have to balance the risks and the benefits. Is it worth it to take these drugs? For which people is it worth it? It clearly is definitely worth it for somebody who has already had a clot. We know that person is going to be at risk of another. It's definitely worth it for that person to take these drugs. It's definitely worth it for somebody who's had bad pregnancy episodes and they've got antiphospholipid syndrome. But is it worth it for people who haven't had those things? So this slide contains everybody in the world. Everybody in the world is on this slide. And I've divided everybody in the world into 4 groups. So you can see on the far left, they're people who have nothing to do with antiphospholipid syndrome. They don't have any positive tests, they've never clot, they've never had a miscarriage. This is the healthy population. They don't ever have to worry about antiphospholipid syndrome. We know those people don't need warfarin or heparin, right? On the far right are the people who have full antiphospholipid syndrome. They've had the clinical features, they've got the positive blood test. Clearly these are high-risk people, they need to be treated. The grey area is the 2 circles in the middle. So at the top, there are people who have clinical features which appear to be antiphospholipid syndrome, very similar, but they don't have the test. But at the bottom, this is the group I want to talk about, the group which have blood tests. They have a positive blood test, but nothing has actually happened to them yet. So the question is, what is the risk for a person in that group? Is it worth giving in that group drugs long-term to prevent something which might never happen? So if you had a person like that, if you had a lady like that in this room, and you tested her, and she was a perfectly well lady, nothing wrong, no symptoms at all, and she's positive for those tests, what can you tell that lady about the future? You can tell that lady there are 4 possibilities for her in the future. One possibility is that she will stay completely well and nothing will ever happen to her. It's known that about 5% of all the population will test positive in one of these tests. So many people with this test will stay completely well. Nothing will ever happen to those people. Or that lady may suffer clots but have no problems with pregnancy. Or she might have problems with pregnancy but never have clots. Or she might be in the really unlucky group who have both of those things, clots and miscarriages. And the problem is that as of today, there is no test I can do for that lady which group she's in with 100%. No, the reason I said ladies is because of the miscarriage. I said, because if I call them, when I practiced this first, I said if we're tested with it, but then I realised that I couldn't talk about miscarriages, so that's why I said a lady, you see. So yes, so if it were a lady, I would talk about miscarriages, but if it were a man, I would remove that box completely, because a man can't have miscarriages. So that's why. But yes, men do have antiphospholipid syndrome as well. It's not a totally female disease. Anyway, whether it's a man or a woman of either sex, I cannot tell them what their outcome will be. There is no test that will give you 100% certainty of what outcome will be. And this is why we don't do population screening. Because if you did population screening, you would create a lot of worried well people, people who actually have no reason to worry, need no treatment, and you can't know what to tell them. Now, we as an international community are trying to develop better tests to give people more certainty, but the tests don't exist yet. So what can we do then? What can we actually do? So one thing we do is we can work together. Haematologists who treat blood clotting, rheumatologists like me, obstetricians like Claire, GPs, all working together for the benefit of the patient. That's one thing that we can do. And we can try and use all the information we know about the patient to assess the risk. So not just their antiphospholipid status, but things like their family history, are they smoking, what sort of contraception they are taking, and so on. So you can add up the whole thing to make a calculation of the risk and say, for this patient, you're a high-risk patient or you're a low-risk patient. It's not 100%. We can't say you're definitely going to have it or you're definitely not going to have it, but we can give them an idea, and then you can discuss with the patient the pros and cons of treatment. So it's just slightly new in a new European guideline which has recently been published, is that they're pushing the idea of aspirin in all high-risk patients who are testing positive, even if they haven't had an event yet, because aspirin does do some blood thinning and it is safe, not warfarin, but aspirin. So that's what we can do for people who test positive, but they haven't had an event yet. And what can the patient do? What can a patient do in this situation? Well, there are lots of things that patients can do. Don't smoke. Smoking increases your risk of clotting. It has all sorts of other bad effects on health, but if you're in the situation of having antiphospholipid syndrome, please don't smoke. Discuss the best form of contraception. Some forms of contraception are much likely to give clots than others. They're best avoided if you're a patient with antiphospholipid antibodies. If you find yourself in a situation which predisposes to clots, for example, a long airline flight where you can't move around a lot, you can move around, you can walk, you can wear stockings in some cases, keep hydrated. There are many, many sensible things that the patient can do for themselves, and tell doctors about your condition. If you're planning a pregnancy, tell your GP, tell your obstetrician that you've tested positive for antibodies. If you're going to have surgery, tell the surgeon. They might give you heparin to prevent you from having a clot after the operation. So these are things that patients can do for themselves. So I've kept talking about high risk and low risk, right? So what does high risk mean? So actually, the previous speakers have also talked about this, and it comes back to my original slide where I talked about the tests for antiphospholipid syndrome and how there are now 3 tests, whereas back in the beginning there was only 1 test. If you are positive in all 3 of those tests, which is so-called triple positive people, that puts you in a higher risk group. If the tests come back with a high number rather than a low number, that puts you in a high-risk group. And if you're IgG positive with one type of these tests, that puts you in a higher risk group. So when the doctors have tested you, they can use those tests to help determine what sort of risk there is. So although it's not 100%, there is lots of information to help people to make that decision. So we've talked now about the people who are just testing positive and we don't know exactly what's going to happen. Once you've had your first event, once a person has had this clot, things become much clearer. We know very clearly what the best treatment for those people is. It's not in dispute that anticoagulation is the best treatment. And in fact, it's the only proven treatment, the only treatment which is proven to stop getting another clot. And warfarin is probably the commonest drug which is used, and it works by blocking a number of different clotting factors. It's called a vitamin K antagonist because those clotting factors are dependent on vitamin K. So it's a bit of a blunderbuss. It blocks all sorts of different things. It represses all the clotting, but it does work. It does stop people getting more clots and more strokes. As I said, it's not 100%. People do sometimes get events even if they're on warfarin, but it's good and it's been proved to be good, but it's not used in pregnancy. So when I was talking about my mum and how we wanted to know how they knew this was the right drug, there's a lot of evidence that anticoagulation is the right thing to do for people with antiphospholipid syndrome who've had it. But how do you know what dose of warfarin to give? Okay, that's the right drug, but how do you know what dose? High dose, low dose, what's right? So we know this by looking at the evidence. Over the last 30 years or so, many, many people have published studies on this, either trials where they compared one dose with another, or just results from hundreds of patients followed over the years saying what happened to patients on high dose, what happened to patients on low dose. And because of all that, you can amalgamate all those pieces of evidence in what are called meta-analyses or systematic reviews. And 2 groups did this in the middle of the last decade, Lim and Ruiz Irastorza. And if you actually want to read the references, I've put them on this. But to summarize, they agreed on many, many things. Firstly, they agreed that anybody who with antiphospholipid syndrome who's had a clot ought to be anticoagulated, and that there isn't a safe time to stop. You can't say a year will do it, 2 years will do it, 5 years will do it. There is no number where you can say after that many years, there's not a risk anymore. So it's long-term anticoagulation. I'm sure many of you will be in that situation. You're on long-term drugs for this. As for the higher dose versus lower dose, the consensus really is that people who are in the high-risk groups may need a higher dose, but the people who definitely do seem to need a higher dose are people who've had multiple clots or people who've had arterial thromboses rather than venous ones. Now, what about these DOACs, these direct oral anticoagulants? I don't know if any of you have been in any of the other sessions, but there's been some very heated debate about these DOACs here in this conference. So let me give you the pros and cons. Actually, when they came in, a lot of us were very keen on these drugs because they seemed much better than warfarin. The reason is they're more specific. They target single clotting factors rather than multiple clotting factors, and their effects are much more predictable. You remember how I said with warfarin, you don't know from day to day how it's going to work, so you have to have blood tests. With these, it's much more predictable. You take the same dose every day, it's probably going to do the same thing for you every day, so you don't have to have regular blood tests. That's a big bonus. And they have fewer drug interactions and so on. So in that way, they seemed better. And there's lots of evidence for other conditions which need suppression of clotting, like atrial fibrillation, that they were good in those other conditions. So that was very encouraging, and they would be more convenient for patients in general. So that was what seemed good about them. What the problem is that there have been some trials now, and two major trials have given opposing results. So there was a trial that was Italy recently, and in this trial they used high-risk patients, so the people who were triple positive, so the highest-risk patients. And this trial had to be stopped, and we've heard the story about this a number of times at this conference from Dr. Pengo, who was the leader of the study. And they had to stop it because the people in the rivaroxaban group were doing worse than the people in the warfarin group. They were having worse outcomes. So they had to stop it. They said, look, we can't do this anymore. It's not fair to the patients. We have to stop it. So if you believe that study, you're going to think DOACs shouldn't be used in antiphospholipid syndrome. Conversely, there was a study here in the UK which came to an opposite conclusion, and that study was rivaroxaban is safe and it's just as warfarin. In that study, nobody had any thrombosis at all in neither group. The difference between the two studies was that in the British study, they didn't have high-risk patients. They didn't concentrate on high-risk patients. In the Italian study, they did. So I think the consensus is for the high-risk group, it's probably not a good option. But what about patients who are in a low-risk group? Could it be good for those patients? It's very tricky now because there's been some official evidence that has come out from the European Agency and the MHRA here, which says that they're not really recommending this drug for APS. Now, the people who support it, who did the British trial, are saying, well, that doesn't really make sense because actually there's cutting evidence. It's not all one way. But that currently is the advice which has come out, although it's hotly disputed. So where does that leave a patient who's on the drug? That's the tricky thing. I think where that leaves a patient at the moment is, at the moment, with the advice is, it's probably unlikely that new patients are going to be started on it, except under a trial, and there will be a trial started in the UK soon where they will explain to patients what is entailed. But ordinarily, I think few patients are going to be started on these drugs for APS at the moment. But what about people who are already on these drugs and doing fine? So what about these people? So the main thing I would say to these people, and there may be some people in the audience like this, is don't stop it. The worst thing that one could do is just stop it. If it's going to be changed, it has to be changed in a controlled way and swapped over to warfarin, because warfarin takes a few days to work. So you can't just stop it because you'd then be at risk of bot. So the right thing to do is go and talk to your doctor, your GP or hematologist, say, look, this is the situation, what should I do? They'll look at whether you're in a high risk or a low risk group, and they will give you some advice. So if it's going to change, it should be changed in a controlled way, not just stopped. That's what I would say. So pregnancy in APS has already been covered. I'm not going to talk about it in a lot of details, but you need to see a specialist obstetrician, somebody who knows about this. Steroids are not good. If somebody has not had previous fetal loss, aspirin alone is probably good. And for people who have had APS loss in pregnancy, heparin plus warfarin. And the outcomes are really pretty good for that, in that 70% of these pregnancies will be good, which is pretty standard in terms of all pregnancies, actually. So in summary, what is the current treatment of the antiphospholipid syndrome? The people who have antibodies, they have a positive test, but nothing has ever happened to them. We can't tell for sure, is the bottom line. We don't have any evidence that putting all those people on warfarin would be a good thing. In fact, it would probably be a bad thing, because a lot of those people would be being treated for nothing. But aspirin, particularly with a high-risk group, is good. People who've only ever had a thrombosis in a vein would be on warfarin probably at a moderate dose, but people who've had it in an artery or many, many venous ones would be on high intensity. Pregnancy, aspirin, and daily heparin. But the thing I want to stress is these are all preventive treatments. These are not treatments designed to reduce symptoms. These are treatments designed to stop people getting worse. That's what they're designed for. So the success is if the person doesn't have any other things happen to them in the future. But you might say, what about the symptoms I have every day? If I have fatigue and joint pain and rash, sometimes called livido reticularis, migraine and so on, what about those symptoms? Okay, fine, you're giving me this drug to stop me having a future thing wrong with me. What about today? What are you doing for me today? And the point is that anticoagulation wouldn't necessarily help those symptoms, because those symptoms aren't due to clotting necessarily. Now, there are some people, and I've met some people, who said, actually, not when I went on the drug, I found lots of other ways as well. Now, I don't know why they felt better in lots of other ways, but there's no rationale why they would, and I've met many more patients who didn't. They didn't feel the other symptoms were controlled by anticoagulation. So why is that? So one reason is those symptoms might not be due to APS at all. They might be nothing to do with the antiphospholipid syndrome, because many people who don't have the antibodies have these symptoms. APS is a rare disease. At this conference, that the estimate for how often it occurs is in 2 in every 1,000 people. 2 in every 1,000 people might have APS. Whereas migraines and tiredness and joint pain are very, very, very common symptoms. So the vast majority of people with those symptoms don't have APS. That means a person with APS might have those symptoms just coincidentally. They just have 2 things at the same time. They're not causing each other. If that's the case, the way to treat the other symptoms is symptomatically. So if you have a migraine, take treatment for migraine. It's not that you should have warfarin to get rid of the migraine. You have to be treated for migraine. If you have joint pain, then what you might need is painkillers for joint pains. Or there might be another disease causing it. So, for example, a person with lupus and antiphospholipid syndrome, which many people have, their skin rash might actually be due to the lupus, not to do with antiphospholipid syndrome at all. A person who has fibromyalgia, a far more common illness, fibromyalgia affects between 2 and 5% of all people, whereas APS affects 1 in 2,000 people. A person with fibromyalgia characteristically has widespread pain and tiredness. Nothing to do with the antiphospholipid syndrome. It's a separate illness requiring separate treatment. So it may be that a person who has these daily symptoms and APS has this for another reason which has to be treated separately. But, what if at least some of those symptoms are due to antiphospholipid syndrome? And let's assume then that some of these symptoms are due to the antiphospholipid syndrome. We know that warfarin or the heparin is probably not going to cure them, because it was never designed to cure them in the first place. It was only designed to stop clotting. So what can we do then? Hydroxychloroquine has been useful in some people with these symptoms. Are usually avoided, they often don't work and have too many side effects. But what it comes down to is the only treatments we have are not targeted at the syndrome. They're just repressing all clotting. They're used in all sorts of diseases where you have to repress clotting. They're not specific for this syndrome. They're not looking at what the syndrome is doing inside your body. What we really need is some drugs which actually target what's happening in the syndrome, which we don't have. So where are we going to get them? And that's where the science comes in. How are we going to develop new treatments for this syndrome which are better? So you remember right at the beginning I told you that the early simple idea was wrong. So this is why it was wrong. So first of all, antiphospholipid antibodies bind phospholipids. That was a misnomer. It's not true. Actually, what they bind is proteins which stick to phospholipids. That's what they do, of which the main one is called beta-2 glycoprotein 1. I'm going to show you a picture of it in a minute. So when the antibodies into the beta-2 glycoprotein 1, that complex of antibody and beta-2 goes and hits cells. So in my original diagram, I said it hit clotting. Well, it doesn't really so much. It hits cells, and then the cells are changed in some way, and that causes thrombosis and pregnancy loss. So it's a new way of thinking about things, different than before. And that gives us a lot of openings for discovering new treatments. So here's a picture of beta-2 protein 1, and it's got 5 bits, 5 parts. These are called domains, domain 1 to domain 5. And the most important domains are domain 1 at the top and domain 5 at the bottom. Domain 5 is important because that's the bit which actually sticks to the cells. Remember I showed you that it has to stick to cells to cause the pathogenic effects. And domain 1 is important because for most cases that's the bit which binds to the antibody. So you really need domain 1 and domain 5 to cause this disease. And this is how we think it works. So first of all, you've got an antibody. You can see this up here. This is the antibody molecule. And antibody molecules are Y-shaped. They have 2 arms. So arm can bind beta-2 glycoprotein 1. So what we think happens is that one antibody binds 2 different beta-2 glycoprotein 1 molecules. These are shown in the red. Okay, so now you've got a complex of 3 molecules, 1 antibody molecule, beta-2 glycoprotein 1 molecules. That complex then sticks to the cell by way of domain 5. And when it does that, receptors, special molecules on the surface of the cells, they come to join the party. They're brought in here. They're switched on. That changes some signals inside the cell, and then the cell changes its behavior to promote thrombosis. This is what we think is actually happening in this disease. And that means there are lots of places where we could design treatments to attack that. So we could get rid of all the antibodies. And there's a way to do that. There are drugs which get rid of the cells which make antibodies. There's one called rituximab. It's widely used. It's used in lymphoma. It's used in lupus. It's used in rheumatoid arthritis. You can get rid of cells. You can do that with drugs. You could make a drug which stops the antibody sticking to the beta-2 in the first place. You could make a drug which stops the beta-2 sticking to cells. You could make a drug which blocked the receptors. You could make it which blocked the signaling. And there are more and more things. We've heard other things at this conference, other new ideas that people have had. Now, I'm not showing you this slide so you remember it all. I'm showing you this slide to show you how much hope there's for new treatments for the antiphospholipid syndrome. Okay? There are so many different things that people are trying to be better than warfarin and heparin. So here are some drugs that are already being tried, and we've heard about in these conferences. Some of these drugs, as on the left side, are adopted from other diseases. Somebody's developed these drugs already. They've gone through all the process of testing them to find out if they're safe or not. They've given them to patients. So we can kind of ride that bandwagon. We can just take those drugs and use them in patients, in principle, right? So rituximab kills the B cells, anti-complement drugs, anti-receptor, anti-signaling, anti-TNF, that's something which is going to be used in pregnancy in a trial. And there are other drugs which we might have to make for ourselves because nobody at APS is going to be interested in those, domain 1 blockers and domain 5 blockers. And all the ones which I'm showing you in red have been described at this conference. There have been talks about these drugs and how they might work and how people are doing research in them. This conference right here in Manchester. The work is going on all the time. So there is every hope that soon there will be new agents for antiphospholipid syndrome which will have less side effects than warfarin and which might treat some of those other symptoms that was not touching. So that's the hopeful side. But will we use them? If these new drugs can be brought in, will we use them? Remember, some of these drugs are already available. I told you, other people are using them for other diseases. Or to put it another way, why do things change so slowly in this disease? We're still using the same drugs that we were using in the 1980s and the 1990s. Why is that? And the reason is another philosophy thing. It's the philosophy of why people adopt new drugs for diseases. In order to do that, you have to prove that the new drug is worth using. And the standard way of doing that is what's called a randomized controlled trial. And unless you can prove that the new drug works in a randomized controlled trial, it is really, really difficult to make change. So in a trial, you divide your group of patients into 2. One half of the patients gets a new drug, the other half gets the standard drug, and then you have to prove that the new drug group did better than the old drug group, or at the very least have to do no worse and have fewer side effects. And the real difficulty is that this is hard to achieve in APS. And this is another place where patients are going to be absolutely critical to the future, and I'm going to explain why. I'm going to explain why with an example. So here's my imaginary trial in APS, and the number of patients in the trial is 2 times X, 2X. And I've divided them into 2 halves. X patients are going on warfarin, and X patients are going on my new drug, and I'm going to follow them for, say, 2, and at the end, I'm going to count how many get clots. And in order to prove my new drug works, the number of people who get clots in this group has to be less than the number of people who get clots in that group. That's how it's going to work, right? The real difficulty is that not many people are going to get clots in the warfarin group, because warfarin is a really good treatment to prevent clots. So this number here is going to be really small. So this number, to be better than that, is going to be really hard. So let's put some numbers in. Let's say my trial has 200 patients in it. I've divided them into 100 and 100. In that 100 patients on warfarin, maybe 5 might get clots. Of course, we don't want people to get clots, you understand, but that's probably what's going to happen. To give you some real-life evidence, there was a trial done, the DOAC trial in Britain, 110 patients, nobody got any clots, nobody at all. So this number is always going to be very small. So if that number is 5 and that number is 3, do you really believe this drug is any better? It might just be chance alone, mightn't it? Nobody's going to believe that. So let's multiply the numbers by 10. Now we've got 2,000 patients, 1,000 in each group, 50 versus 50. Okay, so now I believe it. Now I believe this is definitely different. This will prove to the people who need to bring in the new drugs that the new drug works. But I needed 1,000 patients, APS to be in the trial. And APS only occurs in 1 in 2,000 people. Where am I going to find 2,000 people with antiphospholipid syndrome? And not just that, 2,000 people who are willing to get into a trial. Because that is a really, really big ask for people. Because what you're asking people to say, you're on a drug which is working for you, which we have 30 years history, and I'm asking you to change to something else. We think it works, but can you chance? Can you? So it's not us who's having to take the chance, it's the patient. And every clinical trial in the history of medicine has only succeeded because patients were prepared to enter the trial. Every clinical trial. And this is the problem. And sometimes, actually, with clinical trials, who is going to consent? It may be only the trickiest cases, the cases who are not really happy with warfarin, the hardest ones to control. And you can see that if only the most difficult case get into the trial, the chances of a trial succeeding becomes much less. And this is why it's so hard to make progress and introduce new things. So look, I don't want to depress you. There are possible solutions to this. Here are some. One is, okay, look, let's take on the nose. We need 2,000 patients. Where are we going to get them? We're not going to just stick in the United Kingdom. We're going to go all over. We're going to go to Europe. We're going to go to South America. And this is really what people do. People do multi-center trials with hundreds or even thousands of patients, but it's really expensive. It's so expensive to do those trials. So to persuade a drug company to invest in that is hard. One of the things we could do is not measure clots. So if you just go how many clots in this group, how many clots in that group, that's always going to be hard. I personally think the way forward is to introduce all those other symptoms, to try and find some way of measuring whether all the other symptoms got better as well. And that might be a way of proving that our new drugs are better than our old drugs. And a way to make it more palatable to patients might be to say, okay, we're not going to stop your warfarin. We won't stop it. You'll still have that. We'll add the new drug. So you'll add the new drug rather than replacing it altogether. It makes it less risky for the patient, but also it makes it much more harder to prove that the warfarin, that the group which had the new drug was better. In the end, it all comes down to patients. I'm absolutely convinced that within the next 10 years or so, there are going to be some trials. In fact, we heard about a trial in America, so I guess very few people here will be asked to be in it, where they're going to do a trial of a drug in pregnancy to see if pregnancy works better. So there are likely trials, and in the end, it's going to be about doctors talking to patients and saying, to advance this disease, would you be willing to be in the trial? And being honest with patients about what that means for them. So to summarize, the current treatment is anticoagulation. It always has been the treatment of this syndrome. And it is preventive in nature. It is designed to stop people getting worse, not to make people better today. The everyday symptoms that people suffer may not be antiphospholipid syndrome at all. They may be due to something completely different, need different sorts of treatment, and they may not respond to anticoagulation. We need to be better at saying to those people who have a positive test what their risk is. We're getting there, but new tests need to be developed. There are new drugs being developed. There are lots and lots of very clever people trying to work on new drugs for APS, but we need to work out how to do the trials. Thank you.
Thank you very much. That was very clear. Excellent. We have a couple of questions before lunch. There's two at the back. The lady in the glasses beside you. Yeah. No. Oh,
thank you.
Sorry.
The trials that were stopped, the DOAC trials, I tried to read a couple of them, and it's probably me being a bit thick, but were those patients on other anticoagulants as well, like aspirin or clopidogrel? It didn't seem to be clear.
Okay. So I don't know the specific answer to that question. Usually, and you're not being thick, by the way, those read that study as well, and the methods section is very, very dense and trying to find out those things. So in general, I think that they would try to avoid them, but the big difference really was, it was very clear that the people in the warfarin group and the people in the rivaroxaban group had different outcomes. It wasn't all about clots. Some people in the rivaroxaban group had things like bleeding or heart attacks and so on, but it got to a point where every trial has an ethics committee, and they just said, look, you can't do this anymore, because if people do worse on rivaroxaban, how are you going to justify it? Do you know if the trial had aspirin as well? I can't remember.
That's a good question. I don't know.
In general, they don't, because it's a confounding factor, so everybody has to be the same. So either everybody would have to have aspirin or nobody would have to have aspirin, otherwise it wouldn't work. So I guess they probably didn't.
And that was just a rivaroxaban. Does it scale up to the other DOAC?
Things like apixaban and things like that. So, okay. So, not necessarily. And actually, in a session here, we heard from Dr. Waller from America, who had been doing a trial with one of the others, and he has had, I think, because they stopped funding it. That was it. It wasn't because of danger.
Right, yeah.
He had, so that was really disappointing. He'd spent years and years trying to make it work, and I think they couldn't recruit enough patients, and they stopped it. So it's a good question, and nobody knows the answer. I think what the European Medicines Agency has done, and I don't blame them for it at all, is they've adopted a safety-first attitude. They've said there's a worry about these drugs, there's an alternative drug that we've been using, so we're going to stop it. Now, the argument against it is warfarin is not completely a safe drug either. So, you know, have they thrown the baby out with the bathwater? It's really controversial. You'll hear strong views on either side.
So is there no chance of zapping the antibodies?
Okay, so we'd love to zap the antibodies. Honestly, we'd love to, and I do think there's a chance of zapping the antibodies. So let me divide your question into the science bit and the practical bit. Scientifically, I think and we've seen studies in mice, and in fact we've done studies ourselves, our own group in mice, where we gave some of these new drugs and the mice didn't get clots, right? So you can zap the antibodies in mice. But translating that into human beings, for all the reasons that I've mentioned, is really hard. So there's definitely a chance.
Yeah. Okay, one final question before we break. There's a...
Relates to family history, you mentioned on the presentation, one of the earlier presentations about G as well. I was diagnosed in 2011, and a couple of years before, my father passed away with acute myeloid leukemia. It's just understanding whether that sort of overlap with other conditions in the blood have any relevance in terms of family?
Just so I'm clear about, you're saying there was a family history of chronic myeloid leukemia, is that right?
He passed away 2 years before with AML. It came out of the blue.
So could that be linked to...
I'm just asking the question
yeah.
in terms of family history, yeah.
So I don't have any link between those. Usually, what I can say is most people who I have met with this syndrome don't have a link to those sorts of things. And I haven't read anything in the literature about a link. I think we have to be very humble as doctors. We don't know everything about genetics. So it's possible that there is a gene which is shared between myeloid leukemia and the syndrome. What I would say is if a patient looked me in the eye and said, I have antiphospholipid syndrome, does that mean any of my family have a higher leukemia? I would say no, on the basis of my knowledge. Is that fair, do you think?
Yeah, that's fine. Yes. Okay, so thank you very much, Anna, sir.